So this is a title that somebody asked me, what's going to be the title, what's going to be the title to talk? And this came from a presentation I heard once, and this is one of the slides when people talk about this aspect of things, that there is suddenly prick up. I have to say that when I was on the railway station yesterday evening in Manchester in the rain and freezing weather, waiting for the train to come down, rather than will a robot take my job, I was more thinking, please, will a robot take my job? But this aspect of artificial intelligence has gripped us really in terms of our interest for decades, if not centuries. Humanity's always been really, really intrigued by the power of things. And I remember growing up with the films like 2001 Space Odyssey that you might remember, Bal, and more recently films like Ex Machina. So this is a topic which has entered into the popular psyche, and people have started to worry that computers are going to become far too intelligent and take over the world, essentially. Other people think that actually computers have already taken over the world and are far too dumb, because we're already using these every day in our daily lives, from things like Amazon, the obvious things, but even predictive algorithms that are used by entities such as Netflix. And I won't tell you what Netflix suggested I should watch last night, Bal. But so it's entered now into, with headlines, into the ophthalmological world. And this doesn't always help us very much when you have headlines that are very sensationalist, even from very well established and respected groups, with pictures and headlines suggesting the demise of physicians. And all this brought about some work by some people in a business school in Oxford, where they looked at the sorts of things that people do and the sorts of things that are likely to become automated in the next couple of, well, actually the next 2 decades. And they wrote a paper entitled The Future of Employment: How Susceptible Are Jobs to Computerization? And people have taken information from that paper and produced websites. And that's where the title of my talk comes from, essentially, that there are many of these websites that are up now where you can essentially type in your job and get a percentage score for how likely it is that you will be out of a job in the next 2 decades. So the good news is, Bal, we're okay. No, so this is what happens when you type in optometrist in the next 2 decades. 14% chance of automation, but dispensing optician, ooh. Now, all this has brought a lot of concern in the media, and in not only in the media now, but also in the scientific groups. So there are a lot of papers coming out about the harm artificial intelligence actually could do to things, and is it going to shake things up too much? Are we embracing it too quickly, and what are the potential pitfalls? But certainly there's concern everywhere. So if you just started to type in "will robots," you all of a sudden get all of this information about the things that people have been worried about. And there's quite an interesting graph that was done a few years ago by some people. I think they're in public relations, but they talked about the way technology gets adapted and brought into the mainstream. So very initially, nobody really knows about things, and there's a short period of research and development. And then all of a sudden, people start taking notice. You remember with the dot-com booms and the website names, and everything gets hyped up to a really sort of fever pitch. And then there's an area where people start looking back and saying, actually, a lot of this might not happen. And finally, we do get to a level eventually where we're using the technology in a sensible way and in a proper way, and it's helping us in society, but it might not be reaching those levels that initially were promised in the initial waves. And some people say this is where perhaps we're sort of entering this sort of era now where we've seen all the things where the potential of AI is, and we're starting to question it in some ways and being a little bit more careful about where we're thinking of introducing it into practice. So rather than will a robot take my job, this is more exact in terms of where I'm going to be coming from in this talk, in terms of artificial intelligence and its integration into everyday clinical care and how we get to that stage. was talking to somebody earlier, and everybody's got their perspective on AI, not just the general public, but also those who regard themselves as specialists or experts in the field. So there are linguists who have their perspectives on AI, there are mathematicians, there are computer scientists, there are psychologists, there are philosophers, and there are clinicians. So I think it's important that you see where I'm coming from. Firstly, I don't have any commercial backing yet in this field, so I'm not sponsored by any big companies like Google or IBM yet. And but I do have some experience with spin-out companies, and that I think is quite useful because it gives you an idea of what things are needed for something to come into clinical practice. I've also worked in terms of device development and spent a couple of decades in the field of clinical research, especially into ophthalmology as a consultant ophthalmologist in Manchester. I've got some interest in AI research in terms of I've pretty much came from a decade or so of work in image processing and analysis, and that's when it wasn't really cool. If I had a symposium on image processing and analysis a decade ago, none of you would have been here, but renaming it artificial intelligence has made it all of a sudden very, very cool. But I have some experience in programming and the limitations of programming and the ins and outs of and the dangers and the pitfalls, I think, are more acutely aware of, I think, from limited experience in those fields. So in essence, then, what I'm going to be talking about, it's taken me a long time to get to what I'm going to be talking about, isn't it? Is a background to artificial intelligence and then some of the challenges we'll have in terms of its implementation. And what I would like to try and get to you is a balanced perspective. So more about what we need to get to that side of the graph I showed you earlier in terms of where we're going to be in a few years' time and what we can be using. So in terms of the background to artificial intelligence, it is a very, very broad term and broad definitions, and there's lots of different definitions, but this is my perception of how we can think about it. So expert systems, I alluded to earlier that I'd spent a lot of time in terms of image processing and analysis, and you can imagine a system where somebody works out an algorithm of how a computer should be instructed to do something that could be regarded as intelligent and writes down a whole different sets of instructions from an expert perspective. And that could be in that group of expert systems. But more recently, we've been developing systems that can actually learn those rules for themselves from the original data. And that's the broad area of learning systems and machine learning. Now, within machine learning, there are lots and lots of different sorts of mathematical algorithms that can be used to achieve that. So we all know about things, statistical techniques like regression analysis, which have been around for years. And neural nets are one form of machine learning, which I'll talk about in a bit. And then one type of neural net is this deep learning, which is where a lot of the excitement and fever is coming from, or has been coming from in recent years. So in terms of expert systems first, images that I've been working with for many, many years are very evident to you, but if a computer was to look at them, rather than seeing an eyeball with a pupil, it essentially sees these images as pixels, and if you enlarge them, you'll get to a level where, on a grayscale image at least, each pixel will have a value for its intensity from 0 to 255. And if you imagine that array of numbers, that matrix of numbers representing the whole image, then you get an idea of what a computer actually sees when it sees this. So it doesn't actually see or perceive it in the same way we do. To the computer, it's just this matrix of numbers. So the challenge then, in terms of basic expert systems and image processing and analysis, is to make calculations actually with this matrix to get out what you want. So, for example, there may be something, and this might have been done, for example, before artificial intelligence for breast scans, for finding carcinomas, where you find areas of high intensity. So there are different mathematical calculations you can make which will enhance small areas of high intensity, or other calculations which will enhance lines going in certain directions. But you can see it's quite difficult to instruct a computer using coding then to do much more complicated things like diagnosis of wet macular degeneration or diagnosis of macular edema. But we have used it to good effect. So this is a system which we programmed to look at the vitreous in an OCT. And from the OCT scan, it looks at the intensity of the vitreous and intensity of these white dots essentially, and averages it up and gives you an idea of the level of vitritis. Now, this is quite useful because in modern day therapeutics, several companies are developing new technologies and new drugs which will treat uveitis. And the one thing you need when you're developing a new drug is a good objective measure. And if you've got clinicians saying, well, I think there's 1+ of cells or 2+ of cells, and they're arguing, and then you don't get the power to see if your drug's having an effect. If you've got an objective system, then you do get that power. And this system is an expert system, but it's been very useful in terms of providing that objective score. Similarly, I won't go through all the systems we've programmed, but this is another example where it's an OCT with a pigment epithelial detachment, and we compared the responses in patients who were on one drug to another in terms of very, very small quantitative measures that wouldn't be visible to the naked eye, and demonstrated that one drug might be better in a certain circumstance than another. And that was using an expert system, again, that we programmed with MATLAB. But I've alluded to you already that there are limitations of expert systems. You can imagine trying to write code that would take that massive matrix of numbers in a big image, 1,000 by 1,000 pixels at least, and somehow translate all that information into an output like this needs referral or this doesn't need referral. And so these massive amounts of information are difficult for humans to interpret, and the making of the rules are quite difficult. Even if you know the rules, sometimes you'll know consciously what something is or isn't, but when challenged into terms of why do you think that, you sometimes realize that actually you might not be able to understand it yourself, why you class something as one thing or another. It's something you've sort of done by gut for many years. So in terms of improving things and improving the scope for machine vision, this is where learning techniques can be very useful. So if rules aren't known, then these techniques can create abstract rules, and this ability to learn from images when there's masses of data can be very useful. So computing power has increased, and some of the algorithms around neural networks in particular have advanced, and at the same time we've all of a sudden got this massive digitization of healthcare information, especially in ophthalmology, with the thousands and thousands of images we see, and all those have come together to create this revolution in terms of the power and potential for machine learning. So I'm going to give a brief overview of neural nets, and I know this is going to be talked about in more detail later on. But essentially, a neural network is a form of learning where you have some input data, and what you want to get to is the output. And information from each of these inputs goes to a separate node, and some calculations are done from it to give a certain output. And these calculations, or the level of these calculations, is what is calculated by the learning algorithm. So when you have lots and lots of input data and you know the outputs, then the learning algorithm can work out what each of these nodes needs to do to these inputs to get the output that will give the best possible result. So there'll be a whole load of data that will be used to train that neural network, and then some of the data left behind to test how well it's done.
And that is the basis of what we call a supervised neural network, where we know what the output is for a whole load of data, and we know what the inputs are. And then this hidden layer is trained up to calculate things based on those inputs. And this is a simple neural network, and the difference is in deep learning, you have much more layers there. So for example, this is a paper that we did where we wanted to look at being able to look at an OCT, and from any OCT in patients with macular degeneration, calculate what the theoretical visual acuity could be. And this could be useful because sometimes we get patients with AMD who also have cataracts, and they want to know, have I got visual, if I take this cataract out, what is my potential visual acuity? And so what we did was we had somebody go through thousands of OCT scans and measure all of these features just at the level of the fovea. So all of these features then were taken as inputs into a neural net. And for each OCT scan, we also knew the visual acuity. So for 1,000 or so images then, all of these inputs were known and the output was known. And the software was able to work out what should happen in this hidden layer here in order to get that correct output. And then a fraction of the data was left behind, so you could do this test at the end on the data that was left behind in terms of what the target vision is and what our expected vision was. We were able to get levels of prediction of visual acuity which were quite similar to the repeatability of visual acuity itself. So given that extreme limitation of how variable visual acuity is, we're able to get really, really good levels of prediction using our system. So moving on to other forms of machine learning, because when you hear in the media, the only thing we're really hearing about now is deep learning. And deep learning has sort of revolutionized things because previously it was difficult to train more than one layer, and now we're able to train more and more layers using special techniques. But it's not the only form of machine learning. This is a paper which is, I think, in press, where we looked at OCTAs, and we looked at specific characteristics of OCTAs to see if we could use them to determine a patient's diabetic status, i.e. were they somebody who didn't have diabetes, or they had diabetes and needed hospital care. And this was, the distinction, for example, between diabetics and non-diabetics was in a group of patients who showed no other signs of diabetic retinopathy, and showed no clinical signs of diabetic retinopathy. And we used a variety of different techniques. This is work done with David Hoyle, where we actually showed, just from limited bits of data, reasonable ROC curves. So actually, one of the techniques that was best in a whole group machine learning for this distinction between diabetic retinopathy and no diabetic retinopathy turned out to be logistic regression. And, that was not quite as sexy as saying it was a neural net or some other machine learning or something that we hadn't heard of before, but that was the actual truth of the matter. But there are other forms of machine learning, such as random forest, which was the best measure for other distinctions we wanted to make. And one of the nice things about this form of machine learning, which is a decision tree, is that you can see visually what the computer's doing with things, which you don't get naturally with a neural net. So when the computer is distinguishing patients, for example, who are normal from diabetic retinopathy, you can see it uses this tree, and it uses this value of adjacent area sum, and if it's below a certain level, it's going to go one way. If it's higher, it's going to go another way. So if you had a system which was going to be used clinically,
and it was giving you an output, understanding the way the computer was working and why it came to that decision could be really, really important. And you're interpreting it. Maybe you're in a slightly different situation. Maybe it's giving you an output which you think is a little bit unusual, or maybe the patient's asking you some questions about the decision making. And that sort of a machine learning apparatus might actually still have lots of value compared to things like neural nets or deep learning. So deep learning, though, is the main thing. And as I said before, it's one of the main uses of machine learning that is coming to everybody's attention in research now and in the media. But rather than having a single hidden layer, there are multiple hidden layers in a deep learning algorithm, and they can be multitudinous. And it's only come from recent years where we've been able to work out systems of training these systems, training all the different layers using newer techniques such as backpropagation, that has allowed us to go from having just a single layer, which was useful but not game-changing, to having lots and lots of layers. And with that power now, we've been able to create machine learning systems, not just for discrete amounts of data, like in the initial papers I talked about, where we maybe had 20 input levels for each patient, but for whole images where there might be millions and millions of pixels. And with all this power now, images themselves are just able to be trained if you have enough and high quality data. And I'm not going to go through all the different ones around because they increase. By the time I finish the sentence, there'll be some other system which will have come about. But there are lots, especially in the fields of diabetic retinopathy screening, where the IDX system was one of the first ones to get FDA approval actually last year in terms of its use through prospective studies. But there are other systems by Google and by many other areas around the world, and also in macular degeneration, where some of the headlines have been made in terms of diagnosing AMD. But it's not just in my field of retina. Anterior segment disease, and specifically glaucoma, shows great promise for the field of deep learning in artificial intelligence. But there are lots of challenges in terms of deep learning. This is just some of them. Firstly, it is data hungry, so it's hard to train a system if you only have 2 or 3 points. And some of the rare diseases, there are diseases that I would have seen in my clinic on Friday just gone that I haven't seen for 5 years or so. And so being able to look at those is going to be a challenge. I spoke earlier about the decision tree type algorithms, and those are quite transparent systems. So if you get to an answer through one of those, you can sort of see the pathway the computer's taken. But neural nets aren't always that transparent. They might come out with an output that you think is a bit unusual, and then if you don't know how it came to it, it might be hard to implement. They're not necessarily well integrated. There's not an easy way to integrate these with prior knowledge, so there may be a mass of decades of research that you know about why you certainly do things, but that's not easy to integrate into the learning systems that neural nets use. And the world actually is changing all the time. So, you'll have a certain drug and you might have a neural net that predicts that that drug needs to be given every month, but then in a year's time there's a completely new drug or a completely different way of imaging, like OCTA has come about. And there isn't a way at the moment that neural nets have any contextual understanding about things. So where you have an OCT image, to the net essentially it is still a big matrix of numbers. And it's a mathematical calculation it does in terms of matching that with historically what it's seen, those sorts of numbers get matched with. So it doesn't necessarily understand that that patient is not very good in terms of their driving now and the impact it's going to have on that patient's life. But it's more important in terms of contextual that small changes in the question you're asking aren't going to be manageable. So if you have somebody with a certain drug and you've got the massive big neural net and it's all based around predicting the effect of that drug, if you doubled the concentration of that drug, somebody says, actually, we've found this is safe to do, there's no way that neural net is going to be able to predict what the impact of that is. We can have a guess, because we have some sort of contextual understanding of these things, and we know a little bit about basic common sense would tell us it might have a great effect. But a neural net or a deep learning system wouldn't necessarily have that. It doesn't have that contextual ability to change like that. And so in many ways, there might still be roles for different forms of machine learning, despite all the headlines. And one expert system that we've used quite recently to great success is this measure of using iris cameras. So we had a challenge where there are kids with this condition called MPS, mucopolysaccharidosis, that affects the cornea and causes clouding of the cornea. This is a really, really rare disease, and there's certainly no money in terms of developing a massive, multi-center billion-dollar system of measuring it, but it is really important to have some measure of it because people are developing drugs to treat MPS, and we want to know if those will help in ophthalmic patients as well. The only problem is we only had about 5 patients upon which to develop a measure. And so that's not enough for traditional neural net, definitely not convolutional neural net would look at images, produce an outcome measure. So this required an expert system, and we were able to do that using expert and what we knew about MPS and what we'd known historically about MPS and where the extragranules are stored and how it affects the cornea, and something about visual psychophysics and something about biology and biochemistry. This expert system now has been used in 2 or 3 trials which have shown that the drug does indeed have benefit to the cornea. And that's something that I don't think could have come about by a traditional deep learning system that's making all the headlines. So one of the things at the end there is the contextual understanding, and this is another area that has been of great interest to me that I've dragged David Hoyle into, and we've had lots and lots of discussions and produced some interesting work on it. So what we're trying to do is develop algorithms that understand a little bit more about how the data was generated, and we've produced a model, for example, of macular degeneration using using information about things like pharmacology and biochemistry and biology of what happens in macular degeneration. I won't go into great detail because it's a sort of 60 or 70 page paper, but essentially this is the model we produce, which is based on differential equations of how edema grows in macular degeneration. And we've taken lots and lots of biological parameters such as binding of VEGF to anti-VEGF, the elimination of VEGF, and we've tried to create, using mathematical equations, a model of what happens then when you inject anti-VEGF into the eye. Now the beauty of this is that it allows us to do virtual experiments. So we then went and plugged input data from some of the big trials. So the VIEW 2 study, for example, which is a big study on use of Eylea, and we took the data from the VIEW 2 in terms of the initial patients that they saw and plugged them into our mathematics. Now this green line here is the results from a big multi-center VIEW 2 study on 1,000 or so patients done in lots of centers around the world, and the results of what happens when you inject Eylea into these patients, which would have cost maybe $20 or so million over a period of 5-6 years. This red line is what we produce from just a purely mathematical simulation. So it's still distinct, but you can see we're sort of getting some useful information there about how drugs are affected. And the beauty of this is it's not just pattern recognition, it incorporates some form of understanding. The algorithms understand a little bit about what's going on with the drug, so that if we then decided there's another drug actually which has twice the binding, we can actually put that into the algorithm and it can work out what the new effect would be. So because it understands about the process, it can make those changes, whereas something that deep learning can't do. And
on a very, very basic level, for example, the algorithms have been looked at. We've looked at some patients who come in with macular edema and found, for example, there are occasions where our algorithm will say that somebody will probably need an injection quite quickly, better than might have been predicted, or at a point where the patient could have been brought earlier to get that injection and improve their care. Now, this is the outcome from this is probably not the important thing, because there are lots and lots of deep learning models which are 100 times more exciting in terms of the power they have. But the beauty about the last couple of slides is that this is based on algorithms that actually understand the processes, which is a completely different paradigm to the artificial intelligence that we've all been hearing about, which is basically based on historical results and how we can map and use those historical results to map to outputs. So this is how I envisage the future might be, where we do have the machine learning, but we also still have a role for expert systems, and we hopefully might have a role for things like computer modeling, so that we can have artificial intelligence but also incorporate into that some level of understanding. So in this fast changing world we're not reliant on systems that can easily become outdated. So I guess that's the first part of my talk, and this artificial intelligence revolution is set, I think, to change the way we do things in certain limited areas. But this is quite an interesting paper, because this thing has been going on for a while. So this is an expert-based system, and it used a set of programming tools that was able to recommend appropriate antibiotics for any infection. And they tested that against infectious disease consultants, and the headlines were very similar to the one I showed you right at the beginning, that computer system beats doc in diagnosing infectious disease. And it seemed to be very useful, and it beat, and it was better than the infectious disease specialists, and it never reached clinical practice. And the interesting thing was this was 1979. So it's not just about showing that we can do these things or produce these headlines. There is a big, big gap in terms of demonstrating the power of something and actually getting something to clinical practice. And that's what the next bit of my talk is on, where actually there is a cycle of development that needs to take place, from the early concepts to refining the data that goes in. And I don't know who it was that said to me, but rubbish in, rubbish out. If you have poor data initially, then you're not going to get a good algorithm. Developing the algorithm is just a small part of that link, and they always need prospective clinical trials, and then there's a whole process of device regulation before you can get to clinical deployment. So in terms of defining concepts first, I think I seem to have, yeah, here we go, this is what I meant to do. We've had headlines about tools replacing doctors, but then they haven't been followed up by plans to use them. And there are a lot of systems that demonstrate AI models that don't necessarily seem like they have a place in clinical care. So recent ones, such for example, being able to determine the sex of a person from a retinal image, it does seem very interesting, but it's not necessarily something that has a direct clinical application. And I think this is where we're going to need to be moving much more into having an idea for the end product of your work right at the beginning. We did some work in Manchester on patient well-being, and certainly taking into account what patients want, and patients seem to want, for example, with AMD, that they see the same doctor and they want to be able to talk about their fears. And things like an algorithm that will do all the work and make the decisions that in a few years' time means that the doctor might not even understand why he's making that decision. It certainly isn't something that a lot of the patients will want. There are other people who have done studies on the acceptance of things like AI, and it seems like as generations come up, there have been a greater acceptance of AI, but then there seems to be an unusual shift where in the most
younger groups, actually there's a shift again back into wanting to have some human contact. And I still lecture for the University of Manchester for the undergraduate optometry students, and it's a Monday morning, 9 a.m, and I'm always shocked because it's webcast, and it's webcast live, and all the lecture notes I have to give them beforehand, and out of the 100 students, there's still more than one person there. There's still quite a few people there, which to me, I think if that happened to me in my day, I definitely would have just stayed in bed. But people do still want to have this human interaction. You know, even though things can be fully automated, there is still this need. And so this sort of concept right at the beginning of working out if what you're producing is going to be something that's going to be finally useful is extremely important. So this is interesting. If I am in my clinic and somebody said to me, what would be the one thing that you would want that's going to make things faster, it wouldn't be a system that's going to be able to look at this OCT and make a diagnosis for me, because I feel I can do that, and that aspect of my work might only take less than a minute looking through an OCT, for example. What takes me 10 minutes or more for each patient is going onto my system and finding out where the blooming image is. Is it on ImageNet? Oh no, is it on, oh, it was on, oh, where did you do it? It was on Optos, oh no, was it on Optos? It was, and then finding the right viewer, and then the viewer takes ages to upload. And I sort of think, Google, please, it's great the stuff you're doing, but some of the stuff we actually need in clinical practice might not create headlines, but it'd be much more useful to have a repository where you can access all data. And that's equally important for things like AI systems. So anybody's coming and they want to develop an AI system, the first thing they might say to you is, right, you're a big hospital, it's Manchester Royal Infirmary, how many OCT scans do you have? I don't know. Okay, well, how many do you think you have for AMD? Well, I don't know. How many Optos images do you have? I'm not sure. How many with this? We don't actually have information on all these things, and it's sort of stored a bit slightly haphazardly. And this is a massive process, and this is probably a bigger process than the actual algorithms themselves in terms of procuring and refining the data. And you know, papers have shown that actually using images of poor quality or where the data isn't there can reduce the efficacy of any output products. And there's also a question around the availability of data in people in different socioeconomic groups. Because what we want in the end is to have systems which work for the whole population and not just the ones who have got the most data. And it may be that those from ethnic minorities or lower socioeconomic groups might not have turned up for as many of their appointments, and we don't have the images for those. So this process is a really key part to the development cycle. In terms of the algorithm development, we've talked about different machine learning methods, and this is the bit where probably you see a paper and it talks about the concept. It doesn't maybe talk too much about the data aggregation, but we'll always talk about the machine learning. And it's important that, it's one of the basic fundamentals, is that you develop the model and use slightly different data to fine-tune it and demonstrate its validity. But then when you're testing the model, you need to have a separate set of information from the original model, and keep some of that information aside so that it's not a biased model that you get to in the end. You talked about football, and this is one of the things that I can't get away from. I've got 3 boys, and seem to have got to a stage now in football matches where we're watching a football match. And I remember 2 or 3 years ago where all the pundits were saying, why don't we got the technology, why don't we bring it in? It's very easy to see if somebody's offside. It's very easy to see if a ball's gone in. It's simple technology. Let's bring it in. And now they're all saying, oh, we really hate this system. And so there's a lesson here, I think, because it's all very well with something potentially sounding like it's quite simple, sounding like it's solving a problem that we all need to solve. But then once you bring it in and it's having to fit into the workflows and fit into the human interactions, it can mess things up. So we have a situation now, I don't know about you, but you're watching your favorite game and somebody scores a goal, nothing happens. So we're watching the last Man City game, the Man City scored, nothing happened, the crowd is quiet, the ball goes to the centre, and then when it's kicked off, that's when everybody suddenly starts cheering, because now they can't be sure until all that's started again. And this is an example of when things have maybe gone a bit wrong, things weren't really thought out. And it's really important then that when you have this system, and you've developed this system and you've shown that it's 99.9% sensitive at picking up these tumours or otherwise, that you study it again, preferably in a different centre or lots of different centres, as part of a prospective clinical trial. And then you need to look at things in terms of the workflow and the human interactions and some of the more legal and ethical implications. Device regulation gosh, it can be a big headache, and this is something that I've had personal experience with some of the devices we developed for a spin-out. The regulations seem to be way behind in terms of technology, and they're struggling to catch up, the laws and how to manage things. So one algorithm, for example, the IDX algorithm, has been fully approved by the FDA, but as a locked system, so its current system has been fully approved. And the FDA even are still working on ways of allowing systems to continually train themselves and improve. How do you do that? How do you, if you go through and you do a full clinical trial and you show that something works with a drug, then that drug is approved and you can use it forever. But what if it's a drug that you're making additional changes to all the time? Do you insist on a new trial every time? Do you have to go through this, year or 2 year long process every time, and how is that managed? And so we're still trying to work out ways that we can do this and work out the device regulation pitfalls. And then finally we're into clinical deployment, and once you have done all that and you've got the regulations, then you need to think about employing it in practice and that will require you to train clinicians. It might be that you've done all those things and all of a sudden your computer hardware falls down, it all crashes because it can't go with the demand, or there are clinicians who can't use it, or what happens if you do have problems with it? Do you have the technical support on hand, and how do the patients respond to it? Do they decide actually that they don't want it and they prefer other systems? And even when you've got it in place, you then need to do audits to see how it's working and assess what the new clinical need is. The new clinical need might be for something entirely different, and then you can start the cycle again. So you can see it is quite a long cycle all in all, and you can see then why, even though systems have been proven to work as far back as 1979, there's still this big gap in terms of the number of systems we actually see in clinical practice, and why there is this period where we're going to have to be a bit more practical now that we've all seen the power of AI, and work out ways that we can get to systems where we're using them daily and appropriately in clinical practice. But there are a couple of things that bits of work that we can do where we can use it and use it today. So this is a paper that again produced with David Hoyle. Now there's a big question in retina at the moment about subretinal fluid. When you have patients with macular degeneration, it's very easy if they've got intraretinal fluid, because you know these patients need injecting. But we're seeing patients on a daily basis, and we're getting to know them. We can see from their facial expressions when you tell them they're going to need another injection, they might wince a little bit, and they don't like having them as often. So we're trying to reduce the number of injections, and some people think that if you have subretinal fluid, it's fluid just underneath the retina, that you can leave those a little bit, and they don't necessarily need injecting, and that saves a lot of injection burden on patients. And there's been a recent clinical trial that demonstrated this. So they took one group where they injected those patients with just subretinal fluid very regularly, and another one where they were a little bit more lax. And they demonstrated that in the lax group, you certainly could get as good results. Now, a clinical trial like that can have 1 or 2 arms, it maybe have 3 or 4 arms. It's very hard for it to have more than that number of arms. You can't really say what happens if you've got X amount of fibrosis, for example, because an OCT isn't like that, and patients don't fit always into those 4 categories. You might have a patient who's got a lot of geographic atrophy. Is that going to make a difference? Or they might have a lot of fibrosis or hyperreflective material. And so what we've tried to do is use artificial intelligence to answer those sorts of questions. And after a lot of tinkering and maths and graphs, this is a graph that we've come up with that tries to answer that. So it's a 4-dimensional graph, so bear with me whilst I try and explain it. What this shows is, with each of these circles, the amount of visual benefit from treating a patient and getting rid of their subretinal fluid. And so what we can see is if you have 200 micrometers of subretinal fluid and you don't have any subretinal hyperreflective material or atrophy, you do get some visual benefit from treating that patient, because that's the change in vision of letters, but it's not massive. If you then add lots and lots of subretinal hyperreflective material, that visual benefit reduces, and if you had atrophy as well, that visual benefit reduces. So if you end up with somebody who's got lots of subretinal hyperreflective material and atrophy, then there's hardly any visual benefit at all from treating those patients. So this gives you a sort of immediate, direct visual set of information that can guide a clinician in their office tomorrow in terms of whether they're going to inject somebody or not if they have macular degeneration with certain features. This is another use of artificial intelligence which we're using on a daily basis. And this is a system that I don't know if you've seen out there, but it uses artificial intelligence to enhance OCTA images. And what they did was they took lots and lots of OCTAs where they'd done a massive amount of averaging, where they'd been able to take lots and lots of images and average them. And then they used information from that to develop a system where you could take a single OCTA, apply this algorithm, a trained convolutional neural network, to remove noise parameters and improve the quality of the output. So this is it in practice, where this is what the OCTA would look like beforehand, before the artificial intelligence enhancements, and this is what it's like afterwards. So that's another example of somewhere where we're using today in clinical practice artificial intelligence that hasn't actually had to go through that full cycle, but it's sort of self-evident. So, will a robot take my job? I think that it looks to me like the technology isn't here to be replacing clinicians. Most of even the bigger companies are backing off from initial headlines. They're talking more about ways of augmenting clinical care. A lot of the diabetic retinopathy systems, for example, at the moment are being used or being advocated to do preliminary screening and maybe direct those patients who need more intense screening from physicians, or to be a backup screener, or to try and maybe work on patients that have been potentially missed. But it is the case that probably in future clinicians will need to know much more about the AI systems and what they should expect from the AI systems, and how to judge one AI system from another and work out which ones you should be incorporating into your clinical practice. Thank you very much.